to get started with our session today on treatment pathways in drug-resistant generalized epilepsy. And Dr. Harris, welcome.
So good evening. First, I'd like to thank the Epilepsy Foundation of Michigan for putting on this conference, and to Russ Derry for inviting me to come speak. And thank you to everyone who's joining now for joining this session. I'm an assistant professor of neurology at the University of Michigan. I am an adult epileptologist, and that is a disclaimer. Though I occasionally take care of children, my expertise is in treating adults, and that's sort of the biased lens through which I'll be giving this talk. The title of this talk is Treatment Pathways in Drug-Resistant Generalized Epilepsies. I have no disclosures or conflicts of interests relevant to this talk. And we'll start with just going over the burden of epilepsy. So epilepsy is a highly prevalent condition. It affects approximately 1% of the world's population. And based on 2015 data from the Centers for Disease Control, this translates to approximately 3 million adults and 470,000 children in the US. Around the world, this is nearly 70 million people have a diagnosis of epilepsy. However, about 1 in 10 people will have a seizure at some point in their lifetime. For the visual learners out there, as a visual aid, imagine a football stadium. In this case, this is Ben Hill Griffin Stadium in Gainesville, Florida. This stadium holds approximately 90,000 football fans on game day and is always sold out. Assuming these folks are a representative sample of Florida in general, at any given game, about 900 folks have epilepsy, which is recurrent, unprovoked seizures. About 9,000 people at that football game previously had or will have at some point in their life a seizure. Out of all patients with epilepsy, about 1/3 of them have generalized seizure types. Genetic generalized epilepsy, or GGE, what used to be called idiopathic generalized epilepsy, accounts for 15 to 20% of all epilepsy syndromes. The mainstay of seizure treatment has always been anti-seizure medications. This chart shows the date each drug was first licensed in either the United States, Europe, or Japan, going back as far as 1853 with bromide. You can visualize sort of here the proliferation of drugs at different time points. And with this third generation of drugs, particularly this big increase in the 90s and in the early 2000s, all the way up to the most recent drugs to come to market with cenobamate. For people with epilepsy of any type, the majority are fully controlled with anti-seizure medications. However, a landmark study out of Glasgow, Scotland, these were patients seen at a single center, a single institution between 1984 and 1997, and it found that over 1/3 of patients were never rendered seizure-free with medications. About 60% are controlled with either the first or second medication in monotherapy, and you can eke out another 4% of seizure-free people with either using anti-seizure medications in polytherapy or a third anti-seizure medication in monotherapy. This data has been updated several times over the years, most recently in 2018, and it showed that despite that bevy of newer anti-seizure medications with new novel mechanisms of action that have been released over the last 20 years, these numbers really haven't significantly changed. There's data to suggest that these rates of drug resistance seen in an all-comers population translate also to the generalized epilepsies, where the range of drug resistance is between 18 and 36%. So you might ask, why does the International League Against Epilepsy keep changing these terms to describe epilepsy and seizures? But there's a couple of potentially good reasons. First, having an agreed upon classification scheme allows patients and physicians to have a common language. Second, it can facilitate research, collection of valuable epidemiological data about epilepsy. And it's important for classification schemes to serve as a foundation for delineating epilepsy syndromes, which informs us about the prognosis and potentially guides therapy. For this talk, we will be focusing on the generalized onset seizure types. Your risk for drug resistance is ultimately dependent on the subsyndrome of generalized epilepsy, but certain risk factors may apply across the board. These include febrile seizures, early onset of epilepsy, having a long history of epilepsy, having multiple seizure types, a history of status epilepticus at some point, developmental delay, and comorbid psychopathology. Certain generalized epilepsy syndromes are classically associated with a good prognosis. These include childhood absence epilepsy, juvenile absence epilepsy, and juvenile myoclonic epilepsy. However, it's now recognized from retrospective cohorts that some of these patients don't ultimately achieve seizure freedom. And this is about 7% in CAE, 11% in JAE, and as high as 40% in patients with juvenile myoclonic epilepsy. It's in the patients with greater functional and intellectual disability that can be due to some sort of underlying genetic, metabolic, remote infectious, or structural abnormalities where seizures may virtually never remit. This is certainly true for syndromes like Lennox-Gastaut syndrome and Dravet syndrome. Lennox-Gastaut syndrome is an epileptic encephalopathy characterized by multiple seizure types. These include tonic, atonic, atypical absence, myoclonic, focal seizures, and generalized tonic-clonic seizures. These patients have intellectual disability and specific features on their EEG that are characteristic of the syndrome. The etiologies are genetic, structural, or metabolic in most cases, and unknown in others. Dravet syndrome is also a rare epileptic encephalopathy characterized by the onset of febrile and afebrile seizures in infancy. Seizures progress to drug-resistant epilepsy, and it's associated with cognitive and functional impairments. About 80% of the cases are associated with a pathogenic mutation in the sodium channel gene, SCN1A. So anti-seizure medications that block sodium channels are generally avoided. There's high rates of drug-resistant epilepsy also in these other epilepsy syndromes I listed here. For example, myoclonic atonic epilepsy or Deuce syndrome is a rare disorder. It causes about 1 to 2% of childhood epilepsies, affecting children aged 1 to 5 years of age. It manifests predominantly with atonic seizures, though other seizures may occur. And about a third of children have persistent seizures and experience cognitive decline. Inborn errors of metabolism includes things like succinate, semialdehyde dehydrogenase deficiency, arginase deficiency, mitochondrial disorders, and then GLUT1 deficiency syndrome is due to impairment of glucose transport across the blood-brain barrier, which causes intractable atypical absences in children. Early recognition is very important in GLUT1 deficiency as it's highly treatable with the ketogenic diet. So why do we care about ongoing seizures? In early life, there are developmental concerns, which are most severe in infancy. There may be regression of skills previously attained, and then lost. Seizures can affect the way neurons connect and talk to each other. In a survey of 1,000 people, epilepsy was reported to impact people's relationships with others, their partners, their children. It affects their sex lives, and seizures result in people being less likely to be married or have children. There are physical effects of seizures and the medications we use to control them. People with epilepsy are at a high risk for decreased bone density, endocrine disorders, high cholesterol, and dyslipidemia. They are more prone to weight changes, either weight increases or weight decreases, and of course injuries. There's a higher risk for injuries and accidents with generalized seizures and when you have frequent seizures, as well as if you have a concomitant diagnosis of attention deficit hyperactivity disorder. potentially deadly events from seizures include drowning, severe aspiration, and status epilepticus. And of course, the most severe consequence of seizures is sudden unexpected death in epilepsy, or SUDEP, and the biggest risk factor for that being uncontrolled seizures, particularly generalized tonic-clonic seizures, though seizures of any type may lead to SUDEP. So what can we do? And that brings us sort of to the crux of this talk, which is the treatment pathways for drug-resistant generalized epilepsies. We'll discuss a bit about medical interventions, the limited surgical approaches, and some interesting applications of neurostimulation. For this content, I did rely heavily on this review article from Huang and colleagues out of Hofstra Northwell in New York, a great article that came out in 2019. They also presented at last year's American Epilepsy Society conference. Huang did, and I've updated it with some newer data. With medicines in drug-resistant epilepsy, there's several considerations, right? We want to use broad-spectrum anti-seizure medications, and it's important to avoid drugs that can exacerbate seizures in generalized epilepsy. So these are generally focal epilepsy medications that either block sodium channels or certain drugs that activate GABA pathways in certain ways. Despite the known risk of exacerbating seizures and lack of evidence supporting their use for generalized seizures, the benefit for some of these drugs has been reported in anecdotal cases when using focal medicines. And to be honest, I've seen that also in my own practice. It's also important to understand the metabolism and the interaction of medications, as these play an important role in polypharmacy. So even with that boom of medications over the past 2 to 3 decades, only 5 drugs have been FDA approved for the treatment of generalized seizures. These are valproate, lamotrigine, levetiracetam, topiramate, and perampanel. Other medications have been approved for Lennox-Gastaut syndrome, for example, clobazam, felbamate, and rufinamide. For tuberous sclerosis complex, everolimus, which is an mTOR inhibitor, as well as vigabatrin, are approved. So I'd like to focus on several relatively newer medications that have been FDA approved within the last 10 years or so. The first is perampanel, which was approved in 2015. I really appreciate the naming of this drug because the makers included its mechanism of action in the name, AMPA. Perampanel is an antagonist at AMPA glutamate receptors, so it reduces the influx of sodium into the postsynaptic neuron. What you need to know is that reduces excitation. There's been phase 3 trial data which found during a 13-week maintenance phase, the drug achieved seizure freedom in 31% of patients with genetic generalized epilepsy versus only 12% patients in the placebo group. In a retrospective review, perampanel significantly reduced seizure rates of generalized tonic-clonic seizures, myoclonic, and absence seizures. The next drug is lacosamide, which is now not so new. It was approved by the FDA in 2009. And although lacosamide also acts on voltage-gated sodium channels, like many of the focal epilepsy medications, it does so in a slightly different way by enhancing something called slow inactivation of sodium channels. And it is probably because of this different way of affecting the sodium channel that it's been shown to have efficacy in generalized epilepsy. In 2016, there was an open-labeled study of patients aged 16 to 65 with genetic generalized epilepsies. This was small, with only 39 patients actually completing the maintenance phase, but found that 64% were seizure-free for at least 6 months and 36% for at least 1 year. Lacosamide has been studied in children with focal seizure disorder and deemed effective and safe, though I'm not aware of any studies in children with genetic generalized epilepsy. The next drug is brivaracetam, and this was approved by the FDA in 2016, again for focal seizures, though it has a mechanism of action akin to levetiracetam. So it makes sense that it would be effective for generalized epilepsy. Patients with genetic generalized epilepsy were included in the initial phase 3 double-blinded randomized controlled trial, and there was a significantly higher responder rate compared to placebo, but they did not get that indication. Clobazam was approved by the FDA in 2011, and although studied in Lennox-Gastaut syndrome specifically, it does deserve some special mention since it has been it's found a broader use for off-label epilepsies, particularly since it became generic in late 2018. Clobazam is a long-acting benzodiazepine. It has a structure that is similar to other benzodiazepines, but slightly different, and possibly because of this slightly different structure and how it attaches to the GABA-A receptor, it has less tachyphylaxis. Tachyphylaxis is the propensity of a drug to, over time, require more of it to get the same effect. And that makes clobazam a very attractive medication compared to other benzodiazepines. The next drug is lacosamide, which, oh, sorry. I think I had a duplicate side in there. We talked about bromurastam, we talked about clobazam. Cenobamate, there we go. Cenobamate is the newest of the medications to come to market. It was approved by the FDA in late 2019 for the treatment of focal seizures. It has a very long half-life and also works on sodium channels through both fast and slow inactivation, and thought to be different than other sodium channel agents. And it also has GABA-A modulation, like benzodiazepines. Based on some promising data from animal models, the company has completed recruitment on a phase 3 double-blind, placebo-controlled randomized controlled trial in patients with genetic generalized epilepsy, and those results are expected to be released by the end of the year. So we're very much looking forward to that. I left a whole page for cannabidiol because people have a lot of interest with this. So cannabidiol, or CBD, is one of 2 major cannabinoids of cannabis, the other being 9-delta-tetrahydrocannabinol, otherwise known as THC. But unlike THC, CBD does not have a major psychoactive component. In fact, it may have mild antagonistic effects at the CB1 and CB2 receptors, where THC exerts its effects. So its abuse potential is considered by the FDA essentially 0. It was approved by the FDA in 2018 in the form of a pharmaceutical-grade extract for the treatment of Lennox-Gastaut syndrome and Dravet syndrome. In rare cases, it was reported to render children seizure-free, which is kind of remarkable in that patient population. However, overall, if you take all comers, its effect on seizure frequency appeared modest. Several studies have now shown a clinically significant interaction with clobazam. It reduces metabolism and increases the serum concentration of clobazam's major active metabolite, N-desmethylclobazam. In some, this has led to sedation, necessitating reduction in the clobazam dose. With the legalization of medical marijuana and now recreational marijuana in Michigan, many of my patients presume they can forego the rigmarole of obtaining pharmaceutical CBD oil. But a word of warning, this tends to be exorbitantly expensive, as the doses needed for seizure benefit make out-of-pocket purchase pretty cost prohibitive. I'll talk briefly on the different diets out there for the treatment of generalized epilepsies, starting with the ketogenic diet. The ketogenic diet first emerged about 100 years ago, then fell out of favor as anti-seizure medications started coming to market. Though it has had a somewhat of a resurgence in the past couple of decades, the diet is highly regimented and leads to the production of ketone bodies through fat metabolism. Why this reduces seizures, it's poorly understood. I don't know, but many possible mechanisms are proposed. It's the first line of treatment in GLUT1 deficiency syndrome and also in pyruvate dehydrogenase deficiency. But it's also found use in other drug-resistant generalized epilepsies such as Lennox-Gastaut syndrome, Dravet syndrome, West syndrome, and Deuce syndrome. It's also found use in acute treatment for refractory status epilepticus. The diet itself is quite rigorous. It requires near perfect compliance to stay in ketosis. Potential adverse effects include weight loss, hyperlipidemia, kidney stones, osteoporosis, and atherosclerotic effects. The modified Atkins diet, or MAD, has been around since 2003 and can be thought of as sort of KD light. It requires a lower ratio of fats to carbs than KD and much less monitoring than the ketogenic diet. Several studies, including randomized control trials, have demonstrated the success of MAD in childhood drug-resistant epilepsy. And it was specifically shown to be effective in adults with generalized drug-resistant epilepsy. For my adult patients who control their own food intake and like to eat, I find that the ketogenic diet is nearly impossible to maintain. And I generally recommend the modified Atkins diet. Lastly, there's the low glycemic index treatment. This was introduced in 2005 by Harvard investigators. This diet is even less restrictive when it comes to carbohydrates, but you can only eat foods with glycemic indices less than 50. Its maximum efficacy takes longer than either ketogenic diet and MAD, which take about 4 weeks to get full effect, whereas the LGIT takes about 12 weeks to take effect. So now a little bit about the surgical approaches. Unlike focal epilepsy, medically resistant generalized epilepsy is not amenable to cure by surgical resection. This is not to say there aren't certain brain structures important in generating generalized seizures, and these are potential sites for intervention. The main surgical procedure to be used in generalized epilepsies has been the corpus callosotomy. This is a palliative disconnection procedure, meaning it's not expected to fully stop seizures. The corpus callosum is the major white matter tract connecting the left and right hemispheres of the brain. It's how they talk to each other. This procedure was first introduced in 1939 to disrupt that bilateral synchrony of epileptic discharges that causes a lot of the dysfunction associated with generalized seizures. You can see in the picture to the right, a typical surgical approach to this structure here. It involves a frontal craniotomy, this frontal lobar extraction and retraction and dissection through the intrahemispheric fissure, and then transection of the callosum. It's most efficacious against atonic seizures and generalized tonic-clonic seizures, though it can be helpful in other seizure types to a lesser extent. The amount of surgery performed impacts the efficacy, with an anterior 2/3 resection being less efficacious, but possibly sparing sensory disconnection syndromes, which are seen in about 12.5% of total corpus callosotomy cases. More recent surgical techniques, seen here on the left, use different methods, but one that's become popular recently is something called interstitial thermal ablation, or LIT. The probe is inserted into the corpus callosum, and it heats at the tip under MRI guidance, and there's real-time temperature feedback to the surgeon allowing them to very accurately and safely ablate the tissue. This technique is beneficial in avoiding the morbidity and complications of an open resection. Corpus callosotomy has another potential use in patients who have generalized epileptiform abnormalities and discharges on their EEG, but they're suspected of maybe not actually having a generalized epilepsy syndrome. Maybe they have a deep focus of their epilepsy and it's rapidly becoming bisynchronous on the EEG and sort of masquerading as a generalized epilepsy. In these cases, the EEG abnormalities following a corpus callosotomy may appear more focal, and this could yield subsequent resective surgery options. Now let's talk a little bit about vagal nerve stimulation. The earliest reports of vagal nerve stimulation date back as far as the 1880s with a New York neurologist named Dr. James Leonard Corning. He experimented with transcutaneous vagal nerve stimulation. His theoretical framework at the time was that based on observations of patients during seizures, he saw that they were flushed. And so he was trying to diminish cerebral blood flow. This led to devices like this one here that not only provided electrical stimulation to the vagal nerve for 1 to many hours, but also provided carotid compression to physically reduce cerebral blood flow. This went out of fashion in the early 1900s, particularly as other anti-seizure medications came onto the market with phenobarbital in 1918 particularly. The modern utility of vagal nerve stimulation is theoretically based on exciting the vagal nerve affecting the nucleus tractus solitarius, which has widespread projections to the brainstem, the thalamus, and the cortex. The VNS device was approved for use in epilepsy in 1997. It is implanted into the chest, typically just underneath the skin, with a lead running underneath the skin and attaching to the vagal nerve here in the mid-neck. The device has been implanted now in over 100,000 patients worldwide, and it's found utility in genetic generalized epilepsies, Lennox-Gastaut syndrome, and Dravet syndrome, though not approved for those conditions. Despite this, about a third of people with VNS implantation have generalized epilepsy. As with all neuromodulatory devices, the effects are not seen immediately. About 40% are responders at 6 months. A responder is defined as a person having greater than or equal to 50% reduction in seizures. This increases to 60% of people at 4 years, and at that point, 8% of people even report prolonged periods of seizure freedom. For atonic seizures, corpus callosotomy has a responder rate of about 85%, but vagal nerve stimulation has a relatively high responder rate of over 50%, and so it may be preferred as an initial treatment given its lower risk and less invasive nature. Ultimately, these two approaches may be complementary in treating atonic seizures. Recent models of the vagal nerve stimulator take advantage of its location near the heart and provide additional stimulation when heart rate breaches a certain threshold, as is seen during seizures. This responsiveness may improve efficacy. Although deep brain stimulation, or DBS, is possibly more applicable to generalized epilepsy, I included responsive neurostimulation here, which is also known as RNS, since it can be utilized in similar brain structures, acting essentially as a DBS device. The RNS seen here, it differs from the DBS because it's a closed loop system. And what that means is it self-corrects. It provides stimulation in response to recording electrical patterns, and you can program those electrical patterns. The generator and computer are implanted into the back of the skull, and it provides stimulation to 1 or 2 leads. It was approved in 2012 for the treatment of adults with medically refractory focal epilepsy. The deep brain stimulation device is implanted similarly to the VNS device into the chest. And it's based on data going back to the 1950s. And based on that, initial studies targeted the anterior nucleus of the thalamus. This nucleus is part of the limbic system and a theoretical node in the spread of initial focal seizures, particularly of temporal lobe onset. So you can see here the anterior nucleus of the thalamus is part of something called the Papes circuit, and you see the mammillary body projects through the mammillothalamic tract, and then the anterior thalamic nucleus projects through the cingulate cortex and the cingulum back to the hippocampus, which is the mesial part of the temporal lobe. Given this theoretical framework, this location for stimulation is not necessarily the best for generalized epilepsy syndromes, though some pre-trial case reports suggested a possible effect in cases of symptomatic generalized epilepsies. A more desirable location to modulate generalized seizures may be the centromedian nucleus of the thalamus, which has more predominant reciprocal connections with the anterior cingulate and the frontocentral cortex. The data to date is only from limited case series. There was a 2013 series of 6 adults with genetic or symptomatic generalized epilepsy from London and Madrid. Patients were blinded to stimulation status for the first 6 months, and this period was followed by unblinded stimulation for 6 months, then a long-term extension phase. 4 of the patients had genetic generalized epilepsies, and 2 had presumed symptomatic generalized epilepsy, but all of their major seizure types were generalized tonic-clonic seizures. A baseline period was recorded for 3 months. Then change in frequency of genetic generalized tonic-clonic seizures was recorded. So the top graph shows the frequency of seizure change by epilepsy type over the first 12 months after implant, which was the primary endpoint of the study. The generalized patients represented by the purple line had an average decrease in seizures by 80%, seen here. The bottom graph breaks out the individual results of patients with generalized epilepsy. So you can see you had several patients who were extreme responders, but everyone responded to some degree. In fact, a couple of these patients, the patient in blue here, never even had the device turned on. It was thought to be simply a lesioning effect from the surgery itself and was rendered seizure-free by that. The patient in purple here was rendered seizure-free initially, also just from lesioning, but after 12 months, seizures recurred, the device was turned on, and seizures remitted again for an extended period of time. So that concludes my talk, actually, fairly brief for the time we were given, but I would like to thank the Epilepsy Foundation for providing me this forum and inviting me to speak.
So yeah, I encourage people, we have a lot of extra time for Q&A, so please, and Dr. Harris, if you don't mind, we could maybe open this up beyond this primary topic, just because we have some extra time, and it actually works out really well at being kind of the end of a full week of sessions, so people may have some remaining questions from their previous sessions even that they could ask. So let's go ahead and look at the couple of questions that we've had so far. Someone asked about Realm of Care in Colorado, which is I believe they're the company involved with Charlotte's Web. Yeah, I'm pretty sure, and that's the artisanal cannabis that was kind of first used in with some efficacy. But maybe just if you can talk a little bit more about kind of the differences between the types of cannabis you might receive through a provisioning center or online versus the Epidiolex, which is the FDA approved version. You mentioned the dosing being, or the amount of CBD being quite different and the cost being an issue. What can you talk just a little bit more about the distinctions and the differences?
Yeah, so my experience with the Charlotte's Web product was fairly limited, but when I was training in New York City some years ago, that was very popular. A lot of my patients were getting that over the, actually mail ordered to them. And I think that there was sort of a mixed response personally among my patients. There's things that you have to consider when being on CBD oil, and I think it's important that your physician is very much involved when you start to take CBD. I mentioned that there's that interaction with clobazam. That's an important one to be aware of, but it can also cause some GI symptoms, which can be problematic in patients, particularly if the patient has cognitive dysfunction and isn't able to tell you about their underlying symptoms. You want to be aware that it's an oil. It can cause GI distress, and it can also cause transaminitis. So you have to be aware that you have to check liver function tests and make sure that those aren't going up when you start it. So that's an important thing to consider when you're starting CBD. The thing I find in my patients the most when they start taking CBD oil from a dispensary of some sort is they come in and they tell me, oh, I'm taking CBD oil now. And I say, oh, good, tell me the dose. And when I find out the dose, I find that it's, several orders of magnitude under what they need to be taking to be having any real effect for their epilepsy. And so, people can take it for other indications for which the doses are unknown, anxiety, chronic pain, but that's not really my expertise. And so I end up often telling them, well, if you want to get any bang for your buck for your epilepsy, you need to be taking a much higher dose, and that's almost always cost prohibitive. As far as the quality and what you're actually getting in the product, certainly the pharmaceutical grade is a very high percentage of CBD as compared to THC. And that's really the ratio you're trying to get. Oftentimes that is a little, it's kind of a black box when you're getting that product from somewhere else. You don't really know necessarily. They may tell you, but there's not any quality control necessarily that's going to ensure that. And so those are sort of the things I worry about a little bit.
Yeah. And if you are doing it, using it for, you've decided this is something that you want to do, as you said, make sure you're talking with your neurologist about it. And then also, getting it tested at an independent third-party lab can give you an objective measure of what you're actually getting, as opposed to what maybe the company tells you you're getting. So yeah, and I think, again, a lot of people, like you said, just are not aware of just how low some of the doses are in the products that you get. So another question asking about SUDEP and whether that's more common in children, and short answer is no. But if you want to talk a little bit more about kind of the epidemiology of SUDEP.
Sure. So it's a good question. SUDEP is, we want to start out, is rare. It's very uncommon, but it does happen. And the longer a person has epilepsy, it's a cumulative risk. So the longer you live with refractory seizures, the higher your chance of succumbing to SUDEP. Most studies have shown that SUDEP is actually less common in children, although there are conditions that are more associated. So for example, Dravet syndrome, which I talked a little bit about, is highly associated with death from seizures and sudden death. But in general, it's been considered lower. That's the official statement from the American Academy of Neurology now, but there have been some studies in the last couple of years that suggested that childhood rates of SUDEP are maybe a little higher than what were previously reported. So you have to take that with a little bit of a grain of salt.
Right, right. And certainly if you look like in older adults, for example, there's probably a significant issue with how the death is coded by medical examiners, because there's so many other conditions often involved in older adults that it may be missed and so underestimated. So yeah, it's luckily we've been working with the medical examiners in Michigan and have worked with them on a form to more accurately report SUDEP. So hopefully we'll be able to get some data from that.
Yeah, so important, because the epidemiology of SUDEP is very much hampered by that exact issue of what are we actually counting as SUDEP. Yeah.
Okay, so have there been any pediatric trials for cenobamate, or any rough estimate as to the availability for pediatrics?
As far as I know, no. I think I mentioned that there is a ongoing trial that hasn't reported yet in genetic generalized epilepsy with cenobamate, which I think is important. And then we'll see what happens after that. I feel like oftentimes these medications end up getting used in pediatrics first before there's actual trial data for them to be used. I think the initial studies went as young as 16 years old with cenobamate, but not younger than that. So my suspicion is after we have these other trials, maybe we'll get some open label type of trials in pediatrics.
Sure. Okay. And would you recommend corpus callosotomy for an infant with infantile spasms who failed vigabatrin and ACTH? They apparently did a surgical workup and did not find a FCD, focal cortical dysplasia, I'm guessing that stands for.
Yeah, focal cortical dysplasia.
Yeah, and metabolic panel came back negative, and whole exome sequencing is pending. So I guess maybe even talk just more generally about corpus callosotomy and its potential application for infantile spasms, for whom other first-line treatments have not worked.
I did give a disclosure that I am an adult neurologist, but my understanding is that corpus callosotomy has been used in the context of in infants before, and this could, theoretically be a helpful tool. It would be something that would have to be discussed at a surgical epilepsy conference. Well, University of Michigan would call it a refractory epilepsy conference. It would probably need a lot of buy-in from the neurosurgeons and the epileptologists and other folks. I mentioned some of the consequences of corpus callosotomy, particularly disconnection syndrome, which is a sensory disconnection between the left and the right side of the brain. And you have to imagine that can potentially have long-term effects in an infant, particularly someone who's developing. However, if the alternative is ongoing refractory epileptic spasms, we know that is also poor prognosis. And so, we might go to something like a corpus callosotomy, because we know that with infantile spasms, if you can find a focus, that can be really game-changing, because if you can take out a focus that's generating those spasms, then kids can do much better.
Okay, great. And question of how come surgery is not used in all generalized seizures that are drug resistant?
How come surgery is not used in all generalized seizures?
Yeah,
so
I guess
corpus callosotomy?
No, I think surgery in general. I think basically it's because there's not a part of the brain that can be safely removed for most
Right.
generalized epilepsies. They're
So
not.
we consider all sort of brain surgeries, whether it's a corpus callosotomy or even any of the neurostimulation devices, to be palliative. Now, with some of the neurostimulation devices, over time, we're learning that maybe a small percentage of people are becoming seizure-free with those. And I think that is interesting and potentially will help move that type of intervention forward. At the University of Michigan, we're just starting to do thalamic DBS, and it's been done on the pediatric side. We have our first case for the adults coming up soon, but those are all cases of focal epilepsy. And so once our neurosurgeon gets more comfortable with that procedure, maybe the opportunity does present itself for stimulation of these other sites that don't have FDA approval, like the centromedian nucleus. I think those are options in people with drug-resistant epilepsy, but I would never promise a cure, and it is a brain surgery. So in general, in those cases, if a new drug can be tried or some other type of intervention, that is preferred.
Okay, and as a follow-up to that, because the neuropace can be, the responsive neurostimulation system can be, the depth electrodes can be placed, or leads can be placed in the thalamus, just like the DBS can. What would be the reason you would choose the DBS over a neuropace with leads placed in the same spot? Because the neuropace also provides the recording, it has the responsiveness feature. Is it partially because, does it relate to invasiveness, be the DBS being less invasive? Does it relate to the fact that the DBS has a different stimulation protocol than the RNS does?
Mm-hmm. I mean, you can make the protocols very similar because they're both highly programmable. Okay. And it is true that now that the DBS, the newest version of it, has this sensing feature also, which measures local field potential and gives the physician and programmer some feedback about what is happening electrically around that area as well. So there is some similarities there. You don't get that same nice recording that the RNS gives you, which can be helpful. You can imagine because you could actually potentially see the response of therapies you're giving. So for example, if you know the signature, the electrographic signature of a seizure, and you give a new medication, you can track that over time. And so that does maybe potentially give a little nod to the RNS, but the RNS requires a bit more of workup before you put it in, and so it's maybe a little bit more, and it's more complicated to use and to program than the DBS system.
Right, and then there's also the step of having to upload data with RNS as well, which I assume you don't have to do for the DBS, correct?
So the DBS, typically, you can get that at visits, but it can be uploaded as well. Okay. But it's not like the RNS, which you really have to upload every week at least.
Yeah. Okay. Someone asked, after having VNS for 23 years, what do you recommend next? I'm on several anti-seizure meds, so it's been a long list of meds for 38 years now. So, so basically, if VNS and meds have been tried, kind of the logical next step would be potentially the modified Atkins diet, or what other, I guess you kind of covered some of the options. What other things would kind of jump to?
Well, first I'd start with making sure that the VNS is optimized, of course, but also there's good evidence in the literature that continuing to try new medications is helpful and important. So, trying medications with novel mechanisms of action, this sort of thing can be helpful. And We know that, over time, your body and your brain may sort of start to get used to a certain mechanism of action, and so changing that up with a new drug can provide new benefit. So I don't think that even if you've tried a dozen anti-seizure drugs that you should give up on medication. You want to continue to be trying new medications. And in the realm of SUDEP, it's been shown that continuing to try medications may reduce SUDEP risk as well. So just to throw that out there. And then, of course, if, seizures are still very bad and you are suffering a lot from them, there are these other interventions, like you mentioned, diets. Modified Atkins diet. There are, good nutritionists. We have a good nutritionist who works with our patients to sort of guide them through initiating and maintaining those diets. And I think that's having a nutritionist as part of the epilepsy team is really, really helpful. It's been sort of a boon to my practice. And then of course, if there are places already doing other these neurostimulatory implants, and so if things, you could even explore that as an option.
Okay. And a couple of follow-ups to that. If a person has an older model of the VNS that does not have the heart rate feature, have you noticed, at least anecdotally or in patients, or has there been any actual published data on the extent to which that new feature reduces seizure frequency?
So the company provides some data that it does have some efficacy. I'm not particularly convinced about it. I think the benefit you're getting is from the sort of cyclical activation of the nerve, mostly. Certain people find that higher doses when they do the magnet are helpful, and so maybe in certain individuals they may get benefit from that extra and longer dose, which is essentially also what happens when it responds to the heart rate. But I don't know that it makes it won't create a huge difference.
And as far as medications, obviously there's trying new medications that you haven't tried yet, but to what extent can you see differences in seizure control simply from changing dosing protocols or changing the timing of doses or possibly having doses that are higher than the kind of generally accepted therapeutic range? Like, I guess, what other things in terms of medication other than switching medications can possibly have a benefit?
So I think that, yeah, that's a good question. And I think that's highly individualized. It depends a lot on what a person tolerates and sort of what they need. People metabolize drugs at different rates. And so you have to, as a practitioner, be conscientious of that. And so, yeah, there's a lot of things that get involved there on how to optimize a medication regimen. We start talking about polypharmacy and the interactions among different anti-seizure drugs. And so that also has to be taken into consideration. And certainly going above the recommended maximum, I guess, is something we do all the time in certain individuals who tolerate it and clearly just need that higher dose to control their seizures. So the goal always is maximizing and optimizing medications without causing side effects that are going to be inhibiting your life in some way or causing you problems.
Right. Okay. So what percentage of...
I lost my audio again. 1 second.
All right.
Apologize.
No worries.
Better connected to.
Okay.
Okay, I'm back.
You're back? All right. So roughly what percentage of your patients with refractory epilepsy also have psychogenic non-epileptic seizures? And then you can talk briefly about treatment for PNES.
Sure. So good question. I don't know that I can give you an exact percentage because I'd probably be lying to you, but we know that PNES is higher in people with epilepsy. And so that doesn't affect the way we treat a person's epilepsy. You know, I've had patients with focal epilepsy and PNES who I've taken through epilepsy surgery and rendered them seizure-free of their epileptic seizures. And so they are treated as separate entities. The treatment for PNES, you know, the PNES doesn't respond to anti-seizure medications, is something called cognitive behavioral therapy. At Michigan, we do this with a multidisciplinary clinic where, you know, a person is seen in initial consultation by an epileptologist, a psychiatrist, a psychologist, and a social worker. And then they go through a 10-week regimented booklet, basically a workbook of cognitive behavioral exercises. And they meet every week and they have exercises to go home and practice. And this is geared towards giving a person insight into the causes, but also to the feelings that lead to PNES events, and helping develop strategies and behavioral techniques to mitigate how that manifests, because PNES is essentially a disabling manifestation of these underlying psychological burdens. And so if you can let that out in a less disabling way, that's the goal, is to make people not disabled and to be able to live their life appropriately.
Okay, great, thank you. Question is there research on stem cell therapy? Maybe you can talk a little bit about Dr. Parent's lab.
So Dr. Parent uses stem cells to research disorders like Dravet syndrome and to understand the mechanisms that lead to cardiac dysfunction and potentially sudden unexpected death in these patients. I'm not aware of ongoing stem cells for treatment of epilepsy, but you know, the current state of genetic research into epilepsy is astounding. It rarely yet has led to what the goal is, which is this sort of this personalized treatment modalities, but that is the ultimate goal. And the more we learn about the polygenetic effects that put people at risk for seizures, both focal and generalized seizures, the more that's going to impact our understanding of treatment modalities for that. And down the line, maybe even there will be stem cell treatments to treat those underlying genetic abnormalities that predispose people to seizures. But I don't think we are quite there yet.
But the basic mechanisms, and you can correct me if I'm way off, but basically you can essentially take skin cell or pluripotent stem cells from like skin or something and basically coerce them to become nerve cells, and then you could potentially even test a medication for a specific individual to see if that medication would work for that individual's neurons. Is that way off?
No, that's certainly you could do that, right? And so that could impact the types of medications we use for an individual, right? I don't think that in Dr. Parent's lab, he's inducing these neurons into cardiac myocytes and then testing how these cardiac myocytes behave. But certainly there are, you could imagine utilizing it that way for this sort of personalized medicine as you just described.
Okay, great. Okay, so another, are there any anti-seizure medications with a long half-life used especially for patients who are not compliant and are are there any kind of long-acting injectables that could be used? That's a good question.
Yeah, so I think that's compliance is such an important topic when it comes to drug-resistant epilepsy, and I didn't really talk about it. Maybe I should have, because we know that missing doses of medication is one of the biggest contributors to breakthrough seizures. And really 100% compliance with medications is what's needed to get the full efficacy from them. And so, things you can do to improve compliance are probably the, other than working on your sleep quality, the number one thing you can do behaviorally to treat your epilepsy. And with my patients, I recommend that all of them use a pill box, have an alarm system, and have multiple modalities to make sure that they're taking their medication as they should be, and not missing any doses. And if they do, to have a plan of what to do. Now, the question of what happens if you miss a dose, what is your risk of having a breakthrough seizure, certainly it might depend on the medication itself. And long-acting medications can be beneficial in that way. Your serum levels aren't going to drop as much if you miss one dose, and will be easy to correct. So there are certain medications that have very long half-lives. For example, clobazam has an incredibly long half-life. The medication itself, clobazam, has a half-life of a bit over 24 hours, but it breaks down into an active metabolite, that N-desmethylclobazam that I mentioned, which is therapeutic and has a half-life of up to 3 days or maybe even longer. And so that's a medication that really stays in your system therapeutically for quite a while. Zonisamide is another medication with a long half-life of more than 24 hours. And so it's a medication that if you miss a dose, your risk of having a breakthrough seizure because of that one missed dose is going to be less.
Okay. Another medication question: will a person respond to the same medication differently at a different age? So in this example, the daughter is on med number 3 following a diagnosis of juvenile myoclonic epilepsy and is now 17. Is it possible that she would respond to a failed med positively later in life, post-adolescence?
Right. So the short answer is yes. The longer answer is it takes a lot of discussion with your epilepsy doctor, neurologist, to determine what was the failure due to. Was it an adequate trial of the medication? Were there dose limiting toxicities? And can we give this drug another try? And does it make sense to give it another try? Was there initially response and then there wasn't? But on the face of it, yes. I commonly will go back to drugs previously deemed ineffective and try them again, and oftentimes you do get efficacy in those cases.
Great. And just a quick question: the medications for generalized epilepsy that you mentioned, presumably some of those also work well for juvenile myoclonic epilepsy, it being a generalized epilepsy?
Yes. Short answer. Juvenile myoclonic epilepsy is the most common of the generalized epilepsies. And historically, when I was training, was told, responds very well to medication. You give people a single medication, they're gonna be seizure free. You don't have to worry about them. But we're meeting, and I'm meeting more of these patients, and we now know from retrospective cohorts that there is a good proportion of these patients who aren't seizure free even with medications, and may even become medically refractory. Which is sort of like a slightly different definition of not just having the occasional breakthrough seizure, but having more frequent breakthrough seizures despite even multi-drug regimens. And so certainly, drugs that would work for generalized epilepsies can work for juvenile myoclonic epilepsy. Things you have to be conscientious about. So for example, medications like lamotrigine work quite well for generalized tonic-clonic seizures, but may or may not exacerbate myoclonus, for example. And so there's those sorts of things you have to be a little conscientious about. But yeah.
Okay. And with JME being sometimes or often a lifelong condition, do you have to be a little more concerned about kind of those long-term effects of anti-seizure medications, particularly the older enzyme inhibitors and older medications?
Of course, and depending on the medication, like you said, especially these older ones, there are things that you have to monitor for. Probably the most common among them is bone health, bone density is important. We're learning that some of the medications we use also contribute to dyslipidemia. And that's not a game ender, but it has to be recognized and treated if it exists. And certainly much older medications like phenytoin have certain long-term effects that are deemed undesirable and probably should be switched if a newer medication is available and tolerated.
Interesting question. Is hacking something that we need to be concerned about with implanted medical devices? I know there's stories about the self-driving cars being hacked and that type of thing. Is that even possible? Is it something you've even read about? Or
it's not something I've read about. For anyone who's had or utilized these devices, you know that to access it, you need to be very close in proximity and have a wand that hovers, within a few inches of the device. That's also true for the RNS, which is in the head. You see the RNS, the wand is placed right against it to be able to activate it. And if it's not right against it, it doesn't activate. And you can spend 5 minutes trying to get your wand right in the right place just to be able to make the changes you want to make. So it would seem that hacking would be, to me, be difficult to do. I don't think it can be done at a distance.
Right. So just be aware of strangers with wands, I guess.
I guess so.
So let's see. So one question I had about kind of in drug-resistant generalized epilepsy is how common is it, like for, let's say, someone who's referred to a comprehensive epilepsy center, for them to have been diagnosed with a generalized epilepsy, and then upon additional diagnostic testing, you find out that in fact they have focal epilepsy?
How common is it? That's tough. I can't give you a number, but it's not unheard of. And I've certainly had several patients in my own practice who that's the case. And I can think of one patient who, I don't know, right? The patient I saw last week who has generalized discharges on their EEG, has what looks like a generalized seizure when they have a seizure, but has a cough at the beginning of the seizure, right? And the cough in many studies as part of an ictal phenomenon has universally been associated with focal epilepsy. And so I wonder, in those cases, I think, particularly when they're refractory, people deserve having that surgical workup to determine, and there are tests we can do, other than just the EEG. We can do PET scans, we can do ictal SPECT scans where a radio tracer is put into the vein at the time of a seizure and is taken up by the area of the brain that is receiving all that blood flow at the time of the seizure, which is, if in a focal epilepsy, should light up a single focus. And so there are these types of tests we can do that can help us. And MEG tests, the MEG test can also help. This is like an MRI, but it uses a magnet to look at the dipole of interictal epileptiform discharges and can find a focus even when our eyes are looking at the EEG. It looks generalized. And so that, these are some of the more advanced types of non-invasive testing that can be done. but even when you get that testing, you may need to do invasive testing. If you suspect sort of like a deep frontal focus, we do bilateral stereo EEG, where the electrodes go through the skull and into the brain to localize a seizure focus. And there are cases, you're embarrassed if you do that in someone who has a generalized epilepsy, because that's a fairly invasive procedure. But if you really want to know, sometimes that's the only way.
Okay, great. So specific question about VNS being proposed for someone's adult son, and he also has a pacemaker, which is already on his left side. So what are your thoughts on a VNS and a pacemaker? He apparently started having seizures 3 years ago.
Should be fine. I think the issue you run into is space. And so you may, the neurosurgeon placing it may say, well, we want to put the device somewhere different. So it doesn't have to be in the left chest. And this is actually something I wanted to talk about, because this is important, particularly for parents and family of kids who are very intellectually challenged and do a lot of picking behaviors, because you may say, well, if it's here, my kid's he's gonna pick at it, it's gonna be a problem. So it can be placed in the back, sort of by the center of the back, where a person can't really get to it. And that can be a bit of a safer place for it for certain individuals, or it could be placed on the contralateral chest. I'm not sure how that would affect the cardiac sensing device. I think if it's in the back, it should still be able to sense the cardiac rhythm, and that shouldn't be a problem. If it's on the right side, I'm not sure.
Okay, great. So how do you balance, the question is, how do you balance medication treatment for people who are still in the discovery phase, where one type of seizure has been identified and sourced, yet the other types of seizures exist? So maybe, how do you select a medication? I'm assuming in that case, if you're not sure if it's focal or generalized, you're going to go broad spectrum probably.
Right. So it depends so much on the history. And this is why history is so important in management of epilepsy, because when we are getting that history, particularly of the different types of spells, we make an opinion about what type of epilepsy we think that is. Do you have multiple spells because you have multiple foci of seizures or different types of seizures? Or is it all a spectrum of the same seizure focus or same seizure type? And so if one of them has been characterized and the physician feels like, well, all of these make sense with the one that we've seen, then if it's focal, you can use a focal seizure medication. If it's general, you would use a broad spectrum or a generalized epilepsy drug. Of course, if it's still a mystery and you're not sure, then yeah, you have to use a broad spectrum agent, and you're somewhat limited, but there's quite a few drugs out there now that can be used.
Okay. Another person asked a couple questions about Lamictal, how it works for focal seizures, and kind of the difference between how Lamictal and Lamictal XR, or extended release Lamictal, work.
I see. So yeah, Lamictal works very good for focal seizure disorders. I use it a lot in my practice. I don't use the extended version all that much. And the reason is the half-life of the extended version really isn't much different from the regular release version. The regular release version could be a once-a-day medication. We split it up twice a day sometimes when we're first starting the medication, or if somebody's not tolerating it very well. There are cases where people are on a very high dose of lamotrigine and they're getting a peak dose effect. And the extended release version cuts off that peak dose a little bit. And so people who have a peak dose effect of lamotrigine, I will sometimes use the extended release version. There may be differences in the way a person metabolizes the extended release versus the regular release. I've seen that a little bit. And so it's important to make sure you have a baseline trough level before you make the change so that you're titrating. It should be a one-to-one exchange, but sometimes it's not. You want to make sure that you are targeting that same serum level.
Okay, great. One thing you mentioned earlier when you were talking about
Oh, shoot.
DBS is
My volume went down again. Sorry, 1 second.
Right.
Battery 5. DSK2OP3A21H0N.
All right.
Okay. I think it was in reference to DBS, but you mentioned a lesioning effect. Can you explain what that means? That there can be basically an inadvertent effect from just simply implantation of a device?
Right. Okay. Sure. So, well, specific to DBS, let's go back a little to the history of DBS. So, DBS of the anterior nucleus of the thalamus, or the role of the anterior nucleus of the thalamus in seizures has been known since the 50s. I think I mentioned Wilder and Penfield, and some of their initial stimulation studies found that they could stop seizures with stimulation protocol of that area. And through the 60s and 70s, through a mixture of sort of individual human cases and animal data, we learned that it should be bilateral, and that we get better benefit when it's bilateral and with higher frequency stimulations. But what they did in that interval time, they would often just do lesionotomies, where they would actually permanently lesion that area, and found that you would get these long-term benefits in seizure control. Although, of course, you might be stuck with the long-term complications of that as well. And so there is a concept when we're putting these small, tiny electrodes into these areas where just the fact of doing that can disrupt the area that's either generating or propagating seizure activity. And occasionally for whatever reason, you would expect that would be a very short-term effect, and usually it is, but rarely people do see these long-term effects from that. But that is the exception and not the rule. Generally, people don't have a lesioning effect, or it's very temporary.
Okay. And is that related at all to? I remember someone mentioning in a presentation about after implantation of the RNS, of there being a kind of almost a honeymoon period where you have a benefit just from implantation that then goes away. Is that similar, or is that something different?
I think that's exactly the same.
Okay.
I think that's exactly what's happening. There's some sort of lesioning effect. There may, when we talk about lesioning effects too, we might be conflating it with the general anesthesia effect, where people are undergoing general anesthesia, and that's giving them a bit of a short-term benefit for their seizures as well. And so that also has to be considered. But yeah, those studies that for RNS and for DBS do a period after the implant where you don't do any stimulation, you wait, and you just give it some time before you start doing your study to kind of accommodate for those effects.
Okay, and we just got one more question, and I think this will probably be our last question. It says, I have a VNS, and in the past approximately 5 years, suddenly I was unable to tolerate the discharge. My neurologist has had to turn off the device and gradually then increase the discharge all over. The VNS was checked and was found to be operating properly. Is that something you've heard of before, of someone suddenly having difficulty tolerating the VNS for no obvious reason?
It happens. It's uncommon. It's uncommon. Things you have to be not worried about, but you have to be conscientious about are things like fractures of the lead, microfractures, problems with the device itself, the generator. And so these things need to be checked. Obviously, you can do that by testing the lead impedance of when you're doing a systems check. You can get an X-ray of the lead coming out of the generator and its pathway to the nerve. And then sometimes it just happens that people, the way they tolerate it changes over time. If you're feeling a pain, that could be a problem with the lead itself. But if it's that the typical symptoms that people might get because they're getting activation of the recurrent laryngeal nerve near the vagus nerve, which causes that coughing or that feeling in the back of the throat or difficulty breathing feeling, well, you know, if you're getting that feeling, that the nerve's being activated. So that's almost a good thing, and you can feel that it's safe coming down on the dose because that activation is occurring. Okay.
And you'd mentioned people sometimes picking at the device, if fiddling with the device, like thinking of a child, for example, could that potentially cause the lead to become dislodged or slightly disconnected or something along those lines? That
it could, yeah. And so that's part of the problem if a person is not able to tolerate it, or a child might be picking with it, and so that's why these alternative placement sites can be an option. Typically, you know, if I find that even relatively younger kids tolerate it pretty well, and don't have that problem.
Okay, great. Well, that's great. We went through a lot of questions, and I appreciate your willingness to kind of expand to all epilepsy related questions, and that was great, and kind of a great way to close out this Epilepsy Innovation Conference week. So thank you so much, Dr. Harris, for a really enlightening presentation and conversation afterwards.